Okay, so this talk focuses on special considerations for IVF in the obese patient. There's been a marked increase in obesity in women of childbearing age. In 2015, only 33% of women were classified as being in a healthy weight group, with 33% classified as obese and another 38% of women overweight. By 2035, the healthy weight group will decrease to 28% of the population, while 33% will be overweight and 39% obese. Women of healthy weight are the minority, and overweight and obese is the majority. There's a well-established link between obesity and infertility, such that women who have an elevated BMI have a longer time to conception, increased rates of miscarriage, ovulatory dysfunction, and menstrual irregularity. In some cases, morbid obesity can be so physically restricted that couples are unable to have successful intercourse and thus unable to achieve pregnancy. This past June, an article was published in the New York Times Magazine that discussed the controversy regarding BMI restrictions in IVF. This was a polarizing piece and touched upon the medical and psychosocial impact of obesity in IVF. Obesity impacts IVF in several ways. First, as a woman's BMI increases, gonadotropin requirements increase. IVF monitoring with ultrasound may not be as accurate in obese women as visualization is more challenging. As most retrievals are done in an outpatient setting, anesthesia concerns must be taken into consideration. Most clinics employ mobile anesthesia units, and they are not fully equipped to handle major airway complications that can arise when trying to sedate an obese patient. The egg retrieval itself can be more challenging in an obese woman. Sometimes a transvaginal retrieval is just not possible due to the position of the ovaries or other anatomic factors, and an abdominal retrieval may be necessary. And finally, embryo transfers are done under the guidance of transabdominal ultrasound, making them much more challenging in the overweight and obese population. Most will argue that the reason for BMI cutoffs is this increased anesthesia risk for the obese woman. In a study done at a Brigham and Women's Hospital, they assessed the effect of Class 3, BMI of 40 to 49.9, and Class 4, BMI greater than 50, obesity on oocyte retrieval and complications and outcomes. All patients, regardless of BMI, were evaluated before the day of the procedure by an anesthesiologist, by phone or in person. Patients with a complex medical history or comorbidities had this assessment completed in person. In addition, before treatment, all patients with a BMI of greater than 40 were required to have in-person anesthesia consultation for airway assessment and preoperative planning. A maternal fetal medicine consult and a nutrition weight loss management counseling was strongly advised. Patients with a BMI greater than 60 were not candidates for IVF on the basis of a multidisciplinary consensus group guideline created in conjunction with the anesthesia and MFM divisions. What they found in this study was that there was an increased dose of propofol and fentanyl needed in the obese groups. The overwhelming majority of procedures were performed under total IV anesthesia. CPAP for oxygen desaturation was required in 17.6% of patients with a BMI of greater than 40, compared with only 2.7% in patients with a BMI of less than 40. 14.1% of patients with a BMI of greater than 40 required supplemental oxygen postoperatively for desaturation, compared to only 8% with a BMI of less than 40. They also saw that a transabdominal approach for oocyte retrieval was required in 7% of patients with a BMI of greater than 40 and less than 1% of patients with a BMI of less than 40. The authors concluded that serious intra-op and post-op complications were uncommon in all BMI groups. However, minor complications were more common in Class 3 and Class 4 obesity. And this highlights that IVF can be safely done in a hospital-based setting, although most IVF programs use mobile anesthesia and are not hospital-based. Around the world, fertility treatment is withheld from women above a certain BMI, with these thresholds ranging from 25 to 40 kilograms per meter squared. Resource allocation towards fertility treatment has been extensively debated in countries where fertility treatment is publicly funded. Medical, social, and ethical aspects have been evaluated prior to allocation of resources. Analysis of cost effectiveness, risks and benefits, and poor success rates have led to calls for restricting fertility treatments to obese women. The arguments for a BMI cutoff cite 1. Lower success rates of fertility treatment in overweight and obese women, 2, increased obstetric and perinatal complications, and 3, increased cost of fertility treatment. As for IVF success, a retrospective cohort study of 239,127 fresh autologous IVF cycles was performed with the use of data from the SART-CORS database from 2008 to 2010. Cycles in patients with a normal BMI were used as the reference group. Among this sample size, more than one-half of patients fell into the normal BMI reference range. What they found was that the mean number of eggs retrieved was inversely proportional to BMI. The percentage of cycle cancellations increased with increasing BMI. They found that implantation rate decreased with increasing BMI. Clinical pregnancy rates were highest in the normal and underweight BMI categories, while pregnancy loss rate significantly increased with increasing BMI categories. Most important, live birth rate also decreased with increasing BMI from a high of 31% in low and normal BMI cycles to a low of 21% in cycles with the highest BMI. The study showed worsening of all primary outcomes in the groups with higher BMIs. A direct contributor of success with IVF is selecting the correct embryo to transfer. There has been some debate as to whether aneuploidy rates are higher in obese women. The question is really, does morbid obesity impact the embryo, or does it impact the environment into which the embryo is placed? In a study from NYU in 2015, the authors retrospectively analyzed 279 women ages 20 to 49 who were doing PGT and who had a BMI calculated on the day of egg retrieval. Multivariate logistic regression failed to show statistically significant relationship between BMI and euploidy in underweight, overweight, and obese patients compared with the normal reference range. The authors concluded that the negative impact of being overweight or obese on IVF and reproductive outcomes may be related to factors other than embryonic aneuploidy. There are many principles of bioethics in healthcare decision-making. This leads us to ask the question of whether patients have the right to refuse weight loss and to still access IVF treatments. It also leads us to ask the question of whether doctors should have to treat patients who are at high risk for adverse obstetrical and perinatal outcomes. The ethical principles at play here are autonomy, non-maleficence, and proportionality. Autonomy, allowing or enabling patients to make their own decisions about which healthcare interventions they will or will not receive. Non-maleficence is the principle of not inflicting harm on others, and proportionality is weighing and balancing individual freedom against wider social goods. In summary, one must weigh the risks and benefits in deciding whether to restrict access to IVF for those with elevated BMIs. The arguments against weight restriction favor patient autonomy as the guiding principle. IVF risk is perceived, weight loss is hard, often not successful, and the impact of age is highly significant. The arguments for restriction favor non-maleficence. It can be argued that it is unethical to subject a patient to lower IVF success rates and increased obstetric and perinatal complications. In conclusion, one can justify that it is ethically justifiable to have BMI restrictions for access to IVF treatment. But one should question whether these cutoffs should be just for IVF, or should they encompass all treatments that lead to pregnancy in the obese population. One can also question whether other diseases should be questioned as well. As for the exact BMI above which to restrict, the debate continues. Thank you so much for watching this presentation.